السلام عليكم ورحمة الله. Hello everyone. I'm Dr. Saaed, neonatologist from Iran. We'll talk here about what's the version of ventilation. What we will learn in this lecture. Definition of what's the pressure ventilation. What is the devices uses? What is the position of the neonate? What is the initial setting for PPP? What's the pressure ventilation is an act of providing breath support to the newborn with respiratory disorder. This involves delivery of air or mixture of oxygen combined with other gases through positive pressure to the lungs. Positive pressure can be provided in two forms. Non-invasive positive pressure ventilation is given through special face mask with tight seal. Air flows through the anatomical airways. Invasive positive pressure ventilation involves delivering positive pressure to the lungs via an endotracheal tube or tracheostomy. The ventilation of the newborn lungs is the single most important effective neonatal step in the resuscitation. Learning how to provide PPV is the foundation of neonatal resuscitation. Here in the chart, we see the position of the positive pressure. It comes second to the initial steps. What are the indications? After completing the initial steps, PPV is indicated if the baby is not breathing, apnea, or if the baby is gasping, or if the baby heart rate is less than 100 beats per minute. When indicated, PPV should be started within 1 minute of that. In addition, a trial of PPV may be considered if the baby breathing and the heart rate greater than 100 beats per minute, but the baby oxygen saturation not maintained within the parameter, despite the free flow of oxygen or CPAP. What is the common terminology used here? Peak inflation pressure is the highest pressure administered with each breath. Positive end expirator pressure, PEEP. The gas pressure maintained in the lung between the breath when the baby is receiving assisted breathing. CPAP, continuous positive airway pressure. The gas pressure maintained in the lungs between the breath when the baby is breathing spontaneously. So here's the difference. When we give assisted breathing, the positive pressure between the breath is and when the baby is breathing spontaneously, on the device only maintains the pressure on CPAP. The rate is the number of positive breaths per minute. Inflation time is the time duration in seconds of the inflation phase of each breath of each positive pressure. Manometer is the gauge used to measure the gas pressure. Device is used for PPV, self-inflating bag, Ambu. It fills spontaneously with gas, air, or oxygen, or a blend of both after has been squeezed or released. This is the component of this one, a preserved beat between the breathing with Ambu bag. Low inflating bag, the second one, also called anesthesia bag, only fills when gas from a compressed source flow into it and the outlet is sealed. A flow inflating bag inflates only when the compressed gas source is flowing into the bag and the outlet is sealed, such as when the mask applied to the baby face. If the compressed gas not flowing into the bag, the outlet is not sealed, the bag collapses like deflated balloon. The third one is TP resuscitator. Continuously directs the compressed gas toward the baby. Pressure increases when the opening of the top of the T-shaped device is occluded. This is the machine of it. A TB sustainer is a mechanical device that uses valve to regulate the flow of compressed gas directed toward the patient. Similar to the flow inflating bag device requires compressed gas source. A breath is delivered using finger to the alternatively occlude the release gas escape opening in the top of the TB cylinder. When the opening is occluded, the gas is directed through the device toward the baby. When the opening is released, some gas escapes through the cap, and the position and functional control dials of TB system may vary by manufacturer. This is the shape of TB system. This is the PIP control dial, which controls the and that's the dial controls the TB. How do you prepare to begin post-pressure ventilation? Position yourself as the radiant warmer, the person responsible for positioning the airway. Hold the mask and the baby face and position the baby head. It is difficult to maintain the head and neck and mask in its correct position when standing on the side or the foot of the bed. Team members at the side of the bed are better positioned to access the chest movement. Team members at the side of the bed are better positioned to assess chest movement, listen to the heart and breath sound, and this is the pulse oximeter and cardiac monitor placement. The baby head and neck should be positioned at the midline and neutral, slightly extended in the sleeping position, or as the baby eyes directed upward to the ceiling. Improper positioning is one of the most common reasons for ineffective mask ventilation. The airway will be obstructed if the neck is extensively flexed or extended. Because of the back of the newborn head occiput is prominent, it may be helpful to lift the shoulder slightly by placing a roll towel or small blanket under the baby shoulder. Type of the mask. Natal mask have cushioned, soft, pliable rim, or can be two-shaped, anatomical shape, or round. This is the anatomical. This is anatomical, and this is round. Anatomical shaped masks are placed within the pointed part of the mask over the nose. The mask should be rest on the chin and cover the mouth and nose, but not the eyes. The correct mask will create a tight seal on the face. If the rim of the cushioned mask is improperly inflated, it may be difficult to achieve a good seal. An airtight seal between the rim of the mask and an airtight seal between the rim of the mask and the face is studied to achieve the pressure will inflate the rim. Ventilation will not be successful if there is a large air leak from an improperly placed mask. This is the correct position, A. B is wrong. The face mask covers the eyes, which causing air leak. C is wrong also. The face mask covers the eyes and beyond the chin. This is the mask for the preterm. If you use a large size, there will be no good seal. This is like 35 millimeter and this 10, 50 millimeter. One hand hold. This is the first position if you use one hand for placing the mask. Begin by cupping the chin of the bottom of the anatomic mask and then bring the mask over the mouth and nose. The bottom of the mask should rest on the chin, not below it. The tip of the mask should rest or just below the nasal bag to avoid putting the pressure on the baby eyes or causing a large leak around the eyes. Hold the mask on the face with the thumb and index finger encircling that. Place the other three fingers under the bony angle of the jaw and gently lift the jaw upward toward the mask. Once the mask is positioned, an airtight seal can be confirmed by using even downward pressure on the rim of the mask while holding the head in the sniffing position. Some round masks are designed to be placed directly over the nose and the mouth by holding in place in the stem rather than the rim. If you are applying the pressure on the rim, this type of mask, the mask shape will be deformed and will leak. So this type of mask, you must apply the pressure by the stem, not by the. This is the stem hole. This is the point the top hole. This is the hole. Two hand hold with the jaw thrust. It can be difficult to maintain good seal and the correct head position within one hand. If you cannot achieve a good seal, you use both hands to hold the mask and lift the jaw. Use the thumb and first finger of both hands to hold the mask against the face. Place the other three fingers in each hand under the bony angle of the jaw and gently lift the jaw upward toward the mask. While you concentrate on making good seal and maintaining the correct midline head position, another team member stand at the baby side and squeeze the bag or occlude the TB scalp. A third person monitor the baby response. Precaution. Care must be taken when holding the mask. Do not jump the mask down to the face or occlude the nasal passage. Too much pressure can obstruct the mask, cause air to leak around the side of the mask, inadvertently flex the baby neck and bruise the face. Be careful, do not rest your hand on the baby eyes. Be careful not to compress the soft tissue of the baby neck. Recheck the position of the mask and the baby head at interval to make sure that they are correct position. What concentration of oxygen should be used to start positive pressure ventilation? Studies have shown that resuscitation started with 21% oxygen in term and late preterm newborn, and O2 concentration of 21 to 30 oxygen in preterm newborn as just as effective as a station started with 100 oxygen. To balance the hazard possibly associated with extreme oxygenation, this is program recommend the attempting of maintain oxygen saturation measured with pulse oximeter, close to the saturation measured by healthy baby at the term. Before birth, the fetus has a good oxygen saturation, approximately, uh, sorry, uh, before birth, the fetus has blood oxygen saturation approximately 60%. After birth, the oxygen saturation gradually increases to 90. However, even healthy term newborn may take 10 minutes or longer to reach this saturation. An assistant should place pulse oximeter sensor at the right hand on wrist as soon as possible after PVD started. Once the pulse oximeter reading reliably, so we wait for reliable SpO2 monitoring. Compare the baby preductal oxygen saturation to the range target value summarized in the table. As you see, at 10 minutes, we are even not reaching the 100%. What concentration of oxygen should be used to start PVD? For the initial gestation newborn greater than or equal to 35 weeks of gestation, set the blender at 21. For the initial gestation of less than 35 weeks gestation, set the blender to 21 to 30. Set the flow meter to 10 liters per minute. What is the ventilation rate should be used during the PPV? A breath should be given at rate of 40 to 60 breaths per minute. Count aloud to help to maintain the correct rate. Use the rhythm breathe 2 3, breathe 2 2 3 to regulate the rhythm. Say breathe as you squeeze the valve or include the TP start and release while you say 2 3. After birth, how much the pressure should be used to start PPV? After birth, the fetal lung fluid within the alveoli must be replaced with air for gas exchange to occur. If the baby has not taken spontaneous breath for the first few assisted breath may require higher than usual pressure to move fluid out and the air stays and inflate the alveoli. However, excessively high lung volume and airway pressure can cause lung injury. The goal is to use just enough pressure to inflate and aerate the lung so that the heart rate and oxygen saturation increase. Start with PEP of 20 to 25 cm H2O. Older babies may require higher inflation pressure for the first few breaths to inflate their lungs. After the initial inflating breath, you may be able to increase the inflation. Administering PEEP to the initial inflating breath helps to achieve a stable lung inflation more quickly and remove fluid and prevent the air spaces from collapsing during exhalation. When PEEP is used, the suggested initial setting is 5 cm H2O. Once you inflate the lung, you should see the gentle rise and fall of the chest with each breath. If the baby appears to be taking very deep breath during PPV, you are probably using too much pressure and the lungs may become overinflated. This increases the risk of producing air leak within the lung pneumothorax. Remember that the volume of the neonatal breath is much smaller than the amount of gas in the typical resuscitation bag. If the baby is preterm, usual assessment of the chest movement may be less reliable and there may be a greater risk of injury from overinflation. It is possible to achieve successful ventilation without apparent chest movement. So we assess the response to ventilation by using SpO2 rather than chest. So this is the initial setting for PPV. Oxygen saturation, gas flow. How do you evaluate the baby response to positive pressure ventilation? The most important indicator for successful PPV is rising heart rate. When you start PPV, an assistant will monitor the baby heart rate response. The initial heart rate assessment may be made with a stethoscope. Once PPV begins, assistant should apply pulse oximeter and assess the baby oxygen saturation, and heart rate. Continuous monitoring with the cardiac monitor may be considered. If the PPV has started because of the baby low heart rate, it should be improved rapidly. Within 15 minutes of starting PPV, within 15 minutes of starting PPV, the baby heart rate should be increasing. Within 13 seconds of starting PPV, the baby heart rate should be greater than 100 beats per minute. If the baby rate is increasing after the first 15 minutes, continuous PPV, you will check the response again after 13 seconds of PPV. If the baby heart rate is not increasing after the first 15 seconds, ask your assistant if the chest is moving. If the chest is moving, continue PPV while you monitor your ventilation technique. You will check the baby response begin after 13 minutes 13 seconds of PPV. If the chest is not moving, you may not be ventilating the baby lungs. Perform the ventilation corrective steps described below until you achieve the chest movement with PPV. Here we talk about the Mr. Sofa ventilation corrective step. This is an mnemonic. The ventilation corrective steps are the series of adjustments that you will make the baby heart. The ventilation corrective steps are a series of adjustments that you will make if the baby heart rate is not improving and the chest is not moving. The most likely reason for ineffective mask ventilation are leak around the mask, airway obstruction, and insufficient ventilation pressure. You will perform the corrective steps sequentially until you achieve a chest movement with assisted breath. You may use Mr. Sofa mnemonic. Remember 6 steps in order. Mask adjustment, reposition the head and neck, suction of the mouth and nose, open the mouth, pressure increase, alternative airway. Mask adjustment. Reapply the mask to the face to form a better seal. Indicator of good seal while using TP there and flow inflating part include. Achieve the desired PIP on the device. Maintain the desired PIP on the manometer. Rapid re-inflation of a flow inflating bag between the breath. If a leak is present, just lift the jaw toward. Do not press down hard on the baby face. You may need to use little more pressure on the rim of anatomic mask. The most common place for air leak occur between the cheek and the bridge of the nose. If you continue to have difficulty achieving tight seal, use the two-hand hold described previously. Reposition the head and neck. The airway may be obstructed because of the neck is flexed too far forward or it's overextended. Reposition of the baby head and neck ensure that the midline in the midline and neutral slightly extended. This is the sniffing position. Once you have adjusted the mask and reposition the head and neck, try PPV again and assess chest movement. If the chest is not moving, proceed to the next 2 corrective steps. Suction of the mouth and nose, suction of the mouth and nose with a bulb and syringe. Airway may be blocked by thick secretion. In an unusual situation, thick secretion may block the trachea, and the tracheal intubation or suction may be required. Suction of the mouth and nose. Open the mouth. Opening of the baby mouth may be decrease the resistance to airflow during PPV. Use your finger to open the baby mouth and reapply the mask. After suctioning of the mouth and nose and opening the mouth, try PPV again and assess the chest movement. If the chest is still not moving, proceed to the next step. Pressure increase. Although you have an adequate seal and open airway, inflating the baby lung may require a higher inflation pressure. Use manometer to guide adjustment of inflation pressure. Increase the pressure by 5 to 10 cm H2O in increment until you achieve chest movement. The maximum recommended pressure with face mask ventilation is 40 cm H2O for the term newborn and 30 cm H2O for preterm newborn. After each pressure increase, try PPV again and assess the chest movement. If the chest is not moving with the maximum recommended pressure, proceed to the next step. Alternative airway. Mask ventilation is not always sufficient to inflate the lung. If you have completed the 5 corrective steps and you still cannot achieve the chest movement, you should insert an alternative airway as laryngeal mask or endotracheotomy. Once the alternative airway is inserted, begin PPV and evaluate the baby's chest movement and the breath sound. The baby chest started moving after one ventilation corrective step. What do you do? Now, what do you do? Once you achieve chest movement for each assisted breath, announce the chest is moving now. This ensures that your team aware of your assessment and knows the additional steps are not necessary. Continue PPD that moves the chest for 13 seconds while you monitor the ventilation rate, pressure, and baby heart rate response. If you have difficulty in maintaining this movement during this time, repeat the ventilation corrective steps as needed. Insert alternative airway if you have a persistent difficulty in maintaining effective ventilation with a face mask. After 13 seconds of post-pressure ventilation, what do you do after 13 seconds of post-pressure ventilation that ventilate the lung? After 30 seconds of PPV that ventilate the lung, as indicated by increasing the heart rate and chest movements, you will check the baby heart rate response again. If the heart rate is greater than 100, assisted ventilation has been successful. So continue ventilating at a rate of 14 to 60 breaths per minute. Monitor the baby chest movement, heart rate, and respiratory report. Adjust the FiO2 as needed based on the pulse oximeter. When the heart rate is consistently greater than 100 beats per minute, gradually reduce the rate of PPV and observe for effective spontaneous respiration and gently stimulate the baby to breathe. PPV ventilation may be discontinued when the baby heart rate is continuously greater than 100 beats per minute and sustained spontaneous breathing. The heart rate is at least 60 beats per minute, but less than 100. If the heart rate is improving, continue administering PPV as long as the baby is showing steady improvement. Monitor the oxygen saturation and adjust FiO2 to meet the target saturation range indicated in the table. If the heart rate is not improving, consider each of the following. Quickly reassess your ventilation technique. Is the chest moving? Are you ventilating at a rate of 40 to 60 breaths per minute? Do you hear a breath sound? If necessary, perform the ventilation corrective step. Adjust FiO2 to meet the target saturation. If not already done, placing cardiac monitor and lead to continuous monitoring. If not already done, consider inserting laryngeal mask or endotracheal tube. If available, call for additional expertise to help to solve the problem. The heart rate is less than 60 beats per minute. This is an uncommon situation. Occurs when the heart cannot respond to ventilation alone and require additional support by bringing oxygenated blood to the coronary arteries. Consider each of the following. Quickly assess your ventilation. This is mentioned previously. So key points. Ventilation of the newborn lung is the single most important and most effective step in natal resuscitation. If the infant is not breathing at birth despite stimulation, then the positive pressure ventilation is required. If the infant heart rate is less than 100 beats per minute, then the positive pressure is required. The most important indicator of successful PPV is rising heart rate. If the heart rate is increasing within first 15 minutes of PPV, you do not observe chest movement, start ventilation corrective step. The ventilation corrective steps are mask adjustment, reposition the head and neck, section of the mouth, open the mouth, pressure increase, alternative air. Thank you very much.